All right, everyone, let's talk about an organism that's having a serious identity crisis and causing major headaches in clinical labs. Brucella anthropi. Now, you almost certainly know it by its old name, Ochrobactrum anthropi. But that recent name change isn't just a taxonomic footnote. It's creating some real-world, high-stakes problems for us. So, let's get right into it. Just a quick heads up before we dive deep. Everything we're going over today comes from a Gemini deep search. And if you're the kind of person who loves to go down the rabbit hole of primary sources, and I know many of you are, we've got you covered. The full list of citations is waiting for you in the notebook document that goes along with this explainer. So here's the million-dollar question, right? Imagine this. Your MALDI-TOF pings. The ID comes up, Brucella. What's your next move? I mean, your heart probably skips a beat. Are you dealing with the BSL-2 opportunist you've seen 100 times, or are you looking at a BSL-3 select agent? That one name triggers a whole cascade of biosafety protocols. It's a huge deal, and it's forcing labs everywhere to scramble and rethink their entire workflow. So here's how we're going to break it all down. We'll start with this identity crisis, then we'll hit the lab for ID, talk about what it does to patients, how we treat it, and wrap up with some really important infection control takeaways. All right, Section 1, the bacterium's identity crisis. Let's dig into the big why. How on earth did a bug we've known for years suddenly get saddled with one of the most feared names in microbiology? Believe it or not, this all happened back in 2020, and from a pure science perspective, it actually makes sense. When they did the deep genomic sequencing, they found that the classic Brucella species were basically a branch inside the larger Ochrobactrum family tree. So to clean things up and make the whole family monophyletic, a single neat branch, they decided to rename the whole group under the older, more established name, Brucella. Sounds logical, right? Well, it's a perfect example of a taxonomically elegant solution causing a massive real-world headache for us in the clinical lab. And this, right here, is your get-out-of-jail-free card. This is where good old-fashioned microbiology comes to the rescue. Look, Brucella anthropi is a fast grower. It pops up on McConkey agar just fine. And it's motile, it swims. The classical, dangerous Brucella species, they're the exact opposite. They're slow, they hate McConkey, and they don't move. Honestly, these simple phenotypic checks are your first, best, and most critical line of defense. This is what stops you from having a really, really bad day. Okay, so let's take those clues and build them into a solid workflow for the lab, because if you're not careful, it's really easy to get tripped up here. So when you see it on the plate, what are you looking for? Well, under the scope, it's a gram-negative rod, sometimes a bit on the coccobacillary side. It's not picky at all. It'll grow happily on your standard blood and chocolate augars in normal aerobic conditions. On blood, you're looking for these smooth, convex, kind of pale yellow colonies. On MAC, it's a non-lactose fermenter, so you'll see those clear colonies. And here's a fun one. A lot of techs will tell you it has this really unique popcorn smell. I'm not kidding. And of course, a quick wet prep will show you those little guys zipping around, confirming motility. So let's put it all together into a smart workflow. First, your culture plates and gram stain give you the initial picture. Then your MALDI spits out Brucella. Step 1, don't panic. Step 2, go straight to your phenotypic screen. Check for growth on McConkey, check for motility. If you've got both, you can breathe a sigh of relief. It's almost certainly not one of the scary ones. Now, for the final confirmation, don't rely on 16S sequencing. It's just not specific enough to tell these guys apart. The gold standard, the thing that will give you the definitive answer, is sequencing the REC-A gene. That's what'll nail the ID. Here's another huge clue, and it comes from your susceptibility panel. This bug has a secret weapon. A built-in chromosomal AMP-C beta-lactamase, specifically one called OCH1. What does that mean in practice? It means it's naturally resistant to a whole bunch of penicillins and cephalosporins, even up to the 3rd generation. But, and this is key, it's usually susceptible to carbapenems. So think about it. If you see a non-fermenter that's resistant to something like ceftriaxone but sensitive to meropenem, Brucella anthropi should be jumping to the top of your differential list. Okay, so we've nailed the ID in the lab. Now let's switch gears and talk about the patient. It's really tempting to write this organism off as just a contaminant, but trust me, that can be a big mistake. This thing can be a nasty pathogen. So what kind of trouble does it cause? The number one thing you're going to see by a long shot is catheter-related bloodstream infections, CRBSIs. This bug absolutely loves plastic. It forms these stubborn biofilms on central lines, making it a huge problem for our most vulnerable patients. Think oncology patients, dialysis patients, and while it's less common, it can definitely cause some really serious deep-seated infections like endocarditis or osteomyelitis. And that biofilm ability brings us to what is, without a doubt, the most important rule of treatment: source control. I can't stress this enough. You can throw all the antibiotics you want at it, but if that biofilm is there, you're likely going to fail. For a catheter-related infection, that line has to come out, period. If there's an abscess, it needs to be drained. If you don't get rid of the source, you're not going to get a cure. All right, let's talk treatment. What antibiotics actually work? This is where it gets a little tricky, because we don't have big clinical trials to guide us. We're mostly working off of case reports and what we see in the lab. One of the first hurdles we hit in the lab is with susceptibility testing. If you look at the EUCAST guidelines, you won't find specific breakpoints for Brucella anthropi. They just don't exist yet. The official recommendation is to use the breakpoints for other non-enterobacterales. So what that means for us is that we have to be really careful how we interpret and report these results, and make sure we're communicating closely with the clinical team. But even without specific breakpoints, the data from the lab, the in vitro testing, paints a pretty clear picture. We already know it's naturally resistant to most beta-lactams thanks to that AMP-C. So what's left in our toolkit? Well, the carbapenems, like meropenem, are usually our most reliable big guns. Fluoroquinolones can be a bit hit or miss, so you definitely need to test for those. But trimethoprim, sulfamethoxazole, and the tetracyclines, like minocycline, are often very effective, and that's huge because they give us great options for stepping down to oral therapy. So let's put it all together. You won't find a dedicated guideline for Brucella anthropi from groups like the Dutch Swab, the IDSA, or ESCMID. It's just not there yet. But by piecing together the case reports, we can come up with a solid evidence-based plan. For a typical catheter-related bloodstream infection, you're likely starting with an IV carbapenem, like meropenem. Once the patient's improving and the line is out, you can switch to an oral drug like levofloxacin or TMP-SMX, usually for a total of about 2 weeks. But for those really nasty, deep infections like endocarditis or osteo, you're in for the long haul. We're talking 4 to 6 weeks of therapy, often in combination with surgery. And what about kids? Well, the story's pretty much the same. The vast majority of these infections are tied to central lines, especially in pediatric oncology. The game plan is identical to adults: get that source out and treat based on the susceptibilities you find. The only real difference, of course, is that you've got to be extra careful with dosing, adjusting everything for the child's age and weight. Okay, for our last section, let's pull the lens back and look at the bigger picture. Let's talk infection prevention and what we can learn from past outbreaks. I think this quote just nails it. When you see an outbreak of an environmental bug like this, it's not random. It's not just bad luck. It's a massive, blinking red light telling you that some core safety process somewhere in your system has broken down. And if you want proof, just look at the case studies. I mean, these are sobering. You have a meningitis outbreak from a contaminated solution used for tissue grafts, a bacteremia outbreak because a staff member was diverting drugs and topping off IV bags with dirty saline, a cluster of devastating eye infections tied to surgical tubing that wasn't sterilized properly. Every single one of these points to a catastrophic failure in basic procedure. So the takeaways here are crystal clear. It all comes back to the fundamentals. We're talking strict, obsessive adherence to aseptic technique, sterilization and disinfection protocols that are not just followed, but constantly verified, having quality assurance for everything you bring into the hospital, and moving fast when you even suspect a cluster. Honestly, an outbreak of Brucella anthropi needs to be taken just as seriously as an MRSA outbreak because it's showing you the exact same cracks in your foundation. And that brings us full circle, right back to the central dilemma. This is a question we all need to think about. As our genomic tools get more and more powerful and we rearrange the microbial family tree to be more accurate, are we accidentally creating brand new safety hazards in the clinic? We're stuck in this tug of war between taxonomic perfection and the practical, on-the-ground reality of keeping people safe. And finding the right balance, well, that's going to be the challenge for all of us moving forward. So now I want to hear from you. How has this name change affected your lab? Have you run into Brucella anthropi? What kind of protocols have you had to put in place? Let us know all about it in the comments below. Your experience is incredibly valuable. And hey, if you got something out of this deep dive, do us a favor and hit that subscribe button. We've got plenty more of these coming.